Hello, and welcome to another episode of Vital Times, the CSA podcast. Today, we're going to talk about IUD insertion and pain, and what people can do to help ease a woman's pain with IUD insertion. So, several months ago, I was attending the California Society of Anesthesiologists annual meeting, which happened to be in Anaheim this year, which is great. There were lots of great educational offerings, as well as abstracts and research and poster presentations. One of the posters that really caught my eye was authored by one of my guests today, Dr. Anita Gupta. The poster was on her research looking at the literature surrounding IUD insertion pain. Now, I will admit that as someone who spent the vast majority of my reproductive years, or it felt like the vast majority of my reproductive years, struggling with infertility, I actually don't know that much about IUDs, and I really didn't realize that they were that painful to insert. Her poster also looked at potential treatments for that pain. Interestingly, I think this was before the CDC released its recommendations regarding improved pain management techniques. So, of course, we know Dr. Gupta is a visionary in these things. She is joining us today, I think audio only, because we couldn't get her video to work. And she is a renowned physician, anesthesiologist, pain medicine specialist, pharmacist, and healthcare leader who has been acclaimed for her visionary, patient-centered approach to innovation. Her transformational leadership focuses on human centric care, and particularly in the areas of women's health and pain management, and has garnered her global recognition, including being named a World Economic Forum expert. She's was also the chief surgeon in New York City, and she spearheaded initiatives to improve healthcare delivery and outcomes. Her expertise has been sought by prestigious organizations like the FDA, the Department of Defense, and the National Academies of Sciences, amongst others. And she led the Prescription Opioid Use Task Force on behalf of the American Society of Anesthesiology, championing the expanded access to the life-saving drug naloxone. Her groundbreaking research on revamping pain assessment in hospitals earned her the coveted Association of American Medical Colleges, or AAMC, Learner Award. She's an accomplished author and sought-after voice on complex health issues, and she has shared her insights on high-profile media outlets like Forbes, the New York Times, NBC News, CNN, the Washington Post, and many others. Also joining us today is Dr. Stephanie Cizek. Dr. Cizek is an associate clinical professor of pediatric and adolescent gynecology at Stanford University. She graduated from an OBGYN residency at Kaiser Permanente in San Francisco. She then did a fellowship in pediatric and adolescent gynecology at Cincinnati Children's Hospital. She's currently the medical co-director for the Stanford Clinic for Differences of Sex Development, the co-founder of the Stanford Children's Complex Colorectal Urology and Gynecology Clinic. She is a member of the Stanford Oncofertility Group and serves on the editorial board for the Journal of Pediatric and Adolescent Gynecology. Stephanie is also the fellowship director for Stanford's Fellowship in Pediatric and Adolescent Gynecology. She's also one of my great colleagues, and I've had the pleasure of working with her at Stanford. And really, after reading Dr. Gupta's poster, I actually started asking her more about pain with IUD insertion, and had noticed that over the past year or two, I think it's been, we're suddenly seeing this huge surge of patients coming to the operating room to get their IUD inserted. Granted, I'm a pediatric anesthesiologist, so these are mostly adolescents or young adults who are coming. And so I thought this would be a really interesting topic to talk about for a podcast. Serendipitously, around the same time, there seems to have been an increased amount of media attention, both social media on TikTok, which we'll talk about in a little bit, as well as, from the Washington Post, from CNN, from several other news outlets, around the issue of pain with insertion of the IUD. And of course, the CDC recently released some new recommendations. So I'm going to start with the very basics. Dr. Cizek, would you mind explaining what an IUD is and why it's become increasingly popular for contraception in the US?
Absolutely. Thanks for that great introduction. So, an IUD is a little T-shaped device that's placed into the uterus and can stay there for up to 8 to 10 years, depending on which device you use. They're so popular because they provide excellent contraceptive care. And for contraception, there are, I think, increasing in popularity, especially among teenagers, for lots of reasons, just greater awareness, greater education about IUDs, and I think some old beliefs, old myths that used to be common. For example, there's like a myth that the IUD can only be inserted in the uterus of someone who's had a baby before, and that's not true. So there's a lot of myth busting that has happened throughout the years that I think people are more just aware of this as an awesome, effective contraceptive method. But also more and more, we know that progesterone IUDs have uses that have nothing to do with contraception.
Oh,
For example, the Liletta and the Mirena IUDs are really excellent for menstrual suppression. About 60 or more percent of people who have had it for 1 year have no periods at all, and the people who do have periods tend to have much lighter periods. So they're really great, for example, for kids who have severe developmental delay, who experience severe stress or hygiene concerns during their periods, or for kids who have bleeding disorders. We see a lot of that who have just really severe, heavy menstruation. Kids with gender dysphoria, and their dysphoria is triggered by having periods. So we have a huge transgender and non-binary population who chooses IUD for menstrual suppression or for treatment of dysmenorrhea, which is painful periods, or endometriosis. So there's also been a recent study that showed that the 52 milligram progesterone IUDs are just as good as emergency contraception as the copper IUDs. So lots of uses and tons more that we're learning all the time. So a lot of people who are using them for medical reasons that are not related at all to contraception.
oh, that's great. Who usually places an IUD? Is it always a GYN or someone who's trained in gynecology, or are there other people who
Oh,
do it?
yeah, that's a great question. OBGYNs for sure are probably the most common, but lots of other providers. Family medicine doctors sometimes choose to get training in placing IUDs. Adolescent medicine is a branch of pediatrics that gets special training in teen care, and usually they can place IUDs. Places like Planned Parenthood or medical clinics often have nurse practitioners placing IUDs, and that's actually who placed my IUD. So
Oh,
as a nurse and a P.
oh, that's great. And do you think, or do you know, does everyone get training in pain management for IUD insertion, or is that a little hit or miss?
Oh, it's so I would say not we're not equally trained to provide pain relief, and in fact, I'd say the more the opposite might be true, that we're all undertrained in providing pain relief. And I think this a little bit depends on um, your pathway and even like where you are in your training right now, because it's talked about a lot more for current residents than it was, even when I was a resident and for sure before that. And I think that has to do with a little bit of the way that we approach pain with gynecologic procedures and pain for people with uteruses in general. That is like, something that is unfortunately downplayed or accepted in a lot of levels, even by people within our own OBGYN field. And I think that's changing as it should. And I think in pediatric and adolescent gynecology, we are, I think, one prone to the same kind of biases in training that everybody had, but also our specialized training makes us more versed in trauma informed care. And so I think we just uniquely, as probably as I think sometimes I see even on like the pediatric anesthesia side, there's just some unique ways that we try to reduce pain and anxiety in the pediatric world. Some of which I think could really be easily translated to adult care. Like, for example, I see you all on the anesthesia side, like coating the masks with bubblegum scented oils for kids. And I'm like, why can't we do that for adults?
Yeah, why not? I don't
I
know.
know.
And then all the stuff that they're doing with virtual reality and augmented reality, I mean, why
Yes.
not? I'm going to switch to Dr. Gupta now. So, what inspired you to actually look at this? What inspired you to look at this poster or to look at this topic?
So thank you very much for the opportunity to really share this important research. First of all, this really stemmed from my clinical experience regarding IUD insertion and the pain that stems from it, where I noticed a significant number of patients experience discomfort with the procedure. And so, myself and these really motivated medical students really wanted to explore how to improve the experience. This is a very important therapy, as we just heard, that women need, and we believe that it's critical that we uncover this undertreated, unheard pain that we as experts, that understand pain, that are really focused on women's health, believe, and these passionate students really wanted to uncover, a systematic review of the knowledge that exists. And try to really, come up with proper guidelines on how to help women and what we see. And the reality is, I had one patient in particular, and this I'm sure all of you can appreciate. It's a common story where a woman felt her pain wasn't being treated. She was going doctor to doctor with an IUD that she just simply wanted removed. And she was having, pain that was unremitting. She didn't know what was wrong. And somehow she came to my office, and it was that patient that ultimately got the IUD removed with appropriate care and her pain resolved. And that's what inspired me to explore how to help these women.
Would you mind, if it's not embargoed, and we understand if it is, describing a little bit more about what your research was and what it showed?
Sure. So, we presented this abstract at CSA. So, what we presented there, the key points really was to really develop this pause protocol, which was really developing guidelines to address managing pain during IUD placement. And we looked at a systematic review of over 18 studies from 2019 to 2024, which predates the CDC guidelines.
Right. Yeah.
We looked, which, we had no idea that was going to happen, but we knew, and I was aware because I've worked with, last year I had the good fortune to work with the Gates Foundation and the Innovation Equity Forum, where we brought world experts around women's health to the table and at the NIH. So I had some understanding that pain was a major issue, undertreated, and that it was a priority issue globally. So I knew that this was not necessarily one of the priority issues, but something that I believe, being a pain specialist, needed to be addressed. Mm-hmm. Combined with my experience. So that's why we did this. But we looked at a review article. We looked, and what we uncovered was that there are effective interventions, and many of them we know what they are. As anesthesiologists, we all know what they are. They're pharmacologic, mostly local anesthetics, and non-pharmacological methods using ultrasound guidance, verbal support, and then absolutely using a recommended approach that both addresses the patient needs and reducing pain, which, of course, pain assessment, using topical anesthetics, and ultimately using techniques that are beyond the current standard of care in reducing pain and ultimately improving the patient satisfaction with the IUD insertion. And I think systematically we put together this pause protocol to really advocate for women's health, and understand that the IUD and any treatment for women ultimately and holistically, we should be talking about women's health and pain related to it. And I think that's the fundamental points related to this research.
Can you define what PAW stands for?
It's really, I think really it's just a protocol acronym. I think the students came up with it. I don't think it has any specific,
okay.
The idea is to pause.
I thought, okay.
Before we do the procedure. I think the students really felt that, if you think about it, what is happening during insertion and removal, it's the idea that we should pause, and really think about the pain that women may be having, and really begin to stop and think about what we're doing, that these are procedures that women are having, and really, listen to the patients. I mean, there are now, as I think you're going to talk about in a minute, about the social media, the talk that the social media listening that is occurring online. And I think the medical students came to me with that passionate story that, look, Dr. Gupta, there is so much online. We need to do something about this. And the combination of their passion and, my knowledge and expertise and what I was seeing from clinical experience really drove some of this work to fruition.
Well, that's really wonderful. That's really good to hear. And this is maybe a question for both of you, but I'll have Dr. Cizek go first. Do you think that we're seeing more, hearing more about pain now because as a society we're more vocal and we're more on social media and other platforms? Or do you think it's because, as you mentioned at the beginning, that there's these more expanded uses and now it's not being used? Back in the old days, you said the myth was you put it in women who'd had a baby. And I would assume once you've shoved a baby out of those areas, that you are going to be more able to tolerate an IUD being placed. So do you think it's just that we're more vocal, or do you think it's because it's expanded past kind of childbirth or women who've already had children?
I think it's probably a mixture, honestly, of all these factors. And I think it's a rightful pushback on one, people having pain believed. So there's lots of data on disparities in how much providers believe patients' report of pain based on different racial backgrounds, based on the patient being female presenting, or based on age, like younger people. And I see it all the time still, like people's pain gets dismissed from like period pain, just like, oh, that's just what periods are supposed to feel like. They're supposed to hurt, and like, never mind that this kid is missing school every month and vomiting because of the pain. It's so like, and, but in some ways, I think that like, I credit the TikTok videos and all the social media pressure, like, is in a lot of ways an appropriate reaction to pain not being discussed or addressed in gynecologic procedures, and particularly for IUDs. And because younger people are now using IUDs more and are the ones on social media, I think we're rightfully in some ways having this conversation. I also, as a provider, see how these TikTok videos could sometimes, I have patients now come in with super high anxiety because they saw some TikTok videos and they're, they really want the procedure, but I think it has in some ways been a really appropriate discussion, and to pause and have these conversations with patients about what are the pain expectations and what can we do to control your pain.
Yeah. Dr. Gupta, do you have any thoughts on that too? Oh no, I lost her. Okay, well, back to Dr. Cizek. Hopefully she'll come back in. So we're actually going to go then to the CDC guidelines. What do you think about those, Stephanie?
I think it's actually really great. The previous CDC guidelines just didn't address pain with IUD insertion. They just looked at, who's eligible for IUDs and safety factors kind of associated with that. And now to address pain with IUD insertion in the CDC guidelines it matters hugely. And they did this in two different ways. So one, they did make sure that we are addressing pain. So counseling people on pain expectations with the procedure and pain management options, and making individualized pain management plans that, considers what people themselves want for pain control and who might have higher risk of pain or difficulty with insertion, or just who's even just more anxious about pain. And then two, specifically saying that lidocaine as a paracervical block or topical lidocaine might reduce pain. Is it like they use the word might, so it's not even like the most strong recommendation, but just adding in there at all, addressing that at all, and saying that this could be a way of reducing pain. And since we're counseling people on pain expectations and management options, that this should be a part of that counseling is super, super important.
Do you think, in your experience, does topical lidocaine reduce pain or paracervical blocks or both?
So it's really interesting because, again, like as a resident, I was part of the I think the years where we didn't really talk about, I guess routinely, some of my attendings did, some did not, about lidocaine for or blocks with procedures, especially with IUDs. And at the time that I was doing my fellowship, we didn't use paracervical blocks at all there. Um, Now that I do routinely use paracervical blocks, and I think a lot of places are changing, incorporating this more based on more emerging evidence that this can be effective. I, like in real life, anecdotally see a difference in patients, and that correlates to what many of these studies have shown, that it is uncomfortable itself to put the block in, like that we know that placement of the block can cause some pain with the procedure, but we also know that in a lot of these studies, shows that the peak pain with the procedure is less. And so
Okay.
I think that's how I counsel patients, and most of them end up using the paracervical blocks, and I think it really makes a difference.
Um, I so you do feel like it makes a big difference. I was just going to say that I remember I just remember back. I mean, my issue was the other end of the spectrum, and that was getting all the workup for infertility, including hysterosalpingograms. And I just remember
Oh
how
yeah.
incredibly painful that was, incredibly painful. And it's the usual. Oh, it's just a little pinch. You're just going to feel a little pressure. There's always those words, right? Um, Thank you for getting back to us, Dr. Gupta. I was just going to ask. What do you think about what the current pain recommendations are through the CDC or through just in general? And if you have any particular thoughts about things that really do work better, whether paracervical or topical lidocaine, or I know it was saying in some of the literature that I read that the most common pain discussion that's had is to use ibuprofen or Tylenol, and neither of those things seem to work very well at all in these patients. Has that kind of been your experience?
Yes, yes, and I think that a comprehensive approach is critically important. I mean, I think one, it's not as with pain and with everyone that gets treatment with pain. Common use pain relief methods include both topical anesthesia, which generally is lidocaine, the injectable blocks, as you already mentioned, like a lidocaine or a combined lidocaine bupivacaine injection. There are conscious sedation. What we reviewed. I mean, there are people getting conscious sedation for these procedures, and then obviously non-pharmacological methods. Obviously relaxation techniques, and then as you already mentioned, the pain relief medications, which are available, ibuprofen, acetaminophen. But I do believe, as I was saying earlier, that there is such an unmet need in research around optimal pain management strategies, and really to individualize for each and every patient. And I do think that they're, including myself and many others, are working with the Gates Foundation and other, agencies to figure out how to really improve.
So we mentioned I was going to actually, Dr. Cizek, and you mentioned it too with the sedation. I've noticed this dramatic increase in the number, and granted, again, you and I both work in the Children's Hospital arena, but I mean, 5 years ago, it was once in a blue moon, we would have a patient come to the OR for an IUD placement. My previous place that I worked over 10 years ago, it's once in a blue moon we'd have a patient come to clinic to the OR for IUD placement. Now you guys have like days, block time, where you're spending the entire day doing multiple IUD insertions, which I think is great. I'm not, I'm definitely not um, uh, condemning that at all, but I'm just curious what has led to that, because that's a pretty dramatic and amazing change.
I'm glad you've noticed all the hard work we're doing in the
Yes,
OR.
I do notice.
um, so I would say one thing that is driving what we're specifically noticing in our institution partly is just that we've tripled the number of pediatric gynecologists that we have here now, and we added a peds gyn fellow, and so there's just a lot. We're able to see a higher patient volume, but I think also it's all in the counseling. And I'm also, when I'm working, for example, with other providers who place IUDs, I'm making sure that they're also counseling their patients, even if they're not a surgical provider, that an IUD under anesthesia is an option. And that way they can refer to gynecology if somebody wants that option, because I think many people don't realize that they can have that the procedure under sedation, and so they rule out IUDs altogether in their minds. And when in the pediatric hospital, particularly, we're placing IUDs in people who are really young. Sometimes, from our bleeding disorder clinic or for menstrual suppression, we're placing IUDs in people as young as 9, 10, 11. And you're talking about people who are really not even candidates hardly at all for IUDs in the office. Or for people who are just have super high anxiety related to the procedure, which is a lot of young patients, a lot of patients from our gender clinic. We're talking about people who have never had a pelvic exam before, and some don't really even know what's involved with a pelvic exam. And it's really, I think, offering that option is really a super important part of trauma-informed care, because who am I to know what someone's trauma or pain experience is, or what they're most anxious about here. I can ask, but that doesn't mean people always have to or want to tell me. So for the most part, these are very quick and safe procedures in the OR for most people. Oftentimes we are even buddying up with other things. If somebody's getting another sedated procedure, for example, like a young kid with a developmental delay who's getting a dental procedure at the same time as I know exactly. You knew what I was going to say. We do it all the time. Yeah. So I give all of my patients the options, um, and I think if it's someone who might have extra anesthesia risks, we talk about that too, so we can make a really informed decision. And we talk about the options of, if you're going to be in the office, what does pain control look like there? Pre-medication, and you can have someone in the room with you to help with your relaxation, and you could play a phone video or a song while we're doing the procedure to help distract. And we do the blocks with the paracervical blocks, and we use heat packs, and so all of these different medication based and non-medication based methods for pain control. And then I think you mentioned, Rita, earlier, the VR goggles option. So like virtual reality, we're incorporating that too as like a third option of you don't want to be totally asleep, but you want like more focused distraction. And so we're piloting the use of VR goggles with IUD insertion, because it's been shown to help in other procedures, just hasn't really been tested as much in gynecology, particularly with IUDs.
Dr. Gupta, have you noticed this? So, Dr. Cizek and I both work in the peds world, but have you noticed increased requests from your adult patients for sedation or pain management for IUD insertion?
Yes, yeah. So, right now I'm working primarily in women's health, addressing some of these kind of urgent needs in a community where there is a lot of questions, on how to get either them placed or just removed. And
Okay.
a lot of it is around, and what is surprising, we're in a higher socioeconomic area. What is surprising to me is that you would think in a highly, educated population that the resources would be ample, okay, and they would be enough understanding on how to address a comprehensive, holistic pain control as we're talking about here. But unfortunately, there still is a lack of resources or an understanding on how to treat this and how to remove these in individuals who would want them to be done in a comprehensive manner. And that's the interesting point here. And I think, even with good access to care, we're still not able to provide the best care possible. And so that just, raises the question in my mind, well, where are we then in the U.S. healthcare system, for those who may not even be able to access appropriate pain care. Of course, if, they're in a great healthcare system, we're able to provide all these great treatments, relaxation therapy, and, we can console them, we can provide medications, and we can provide all kinds of things, but blocks, but there are many patients, and I've seen it firsthand, when I worked in Philadelphia, in those who are uninsured or may not even have access to care, who perhaps may not even have the opportunity to even see a specialist. So, that's something that, bears down on my soul on how we're treating these women. Who may in fact are reading things on social media, who want IUDs removed, and perhaps may not have.
Yeah, that's really such that's yeah that's such a difficult part of our healthcare system, is that we have so many resources, but we can't always deploy them in the ways where they can sometimes provide the greatest good. I know in some of the articles that I was reading and preparing for this podcast today, there were women who talked about they had so much discomfort and so much distress with the placement of their IUD that they often put off going back to see their gynecologist or back to see their women's health specialist for years and years and years, because they were just so distressed by it. And others, like in your first story, who had persistent pain after the IUD placement that were sort of ignored and dismissed and diminished. Well, it's the pain of being a woman, right? That's just, you just have to grin and bear it and put up with it.
Yes.
So, and you're right. I mean, we are, I'm up in Northern California. I know you're down in the San Diego area, and we're in very highly resourced and upper economic statuses, and it's difficult sometimes to get what we need here, let alone patients who are struggling. So that's a very poignant point that you just made. So have you guys seen some of these TikTok videos? I did want to I did want to mention them because they're actually pretty dramatic. Some of these. I'm just. I was gonna play. I was gonna play one of them. I don't know if I can get it to make sound on my. Let's see if I can. No, that I can't get the sound to come up on these videos. But I mean, you just have to put in IUD pain on TikTok, and there's a whole series of videos that pop up. And I don't know, I don't understand exactly what the motivation is to even videotape these and put them online. But obviously there are people who find this very useful, and I don't know if it's just to inform other patients that if you're going to get this done, it is quite painful, and be sure to talk about it. I don't know, do you guys have any insight about that? I'll let Anita, you go first this time.
Sure. Yeah, I think. Look, I think it's a double-edged sword here, right? I mean, we know as physicians that that it does place a burden of, well, we don't know what the right thing to do is, right? But it does inform patients on to ask questions, right? And I think that's the important thing, is that now we're getting the questions, and it has led me to do the research that we're here to talk about,
right,
as experts, right? And
yeah.
I think it has put pressure on us to uncover things that maybe we're not asking. And I think that's the important thing that has led to, and the students coming to me, and it has led to this, impetus to do the work. And so it has some positive effect, but in the immediate sense, yes, it is a lot of tension in the rooms and offices when we're examining these patients. We don't always have the answers, and it does create a lot of tension, because a lot of times we don't know, we don't have the answers, we don't have the evidence nor the science. I searched books and textbooks and everything to find out what is the right thing to do, and we don't always know. And that's the unfortunate part about this, is that we are trying to do the best for everyone and provide the best care, but and try to provide the most compassionate care. But it is very difficult when the research is just not there.
Stephanie, what do you think?
I was laughing as you were talking earlier, because I think I recently saw a TikTok video where it was showing a gynecologist being like, "This is just gonna be a twinge," and then she picks up like a chainsaw, and you're like, "Oh my God!" Like that's so.
Oh, I've seen these videos. They are so funny.
They are. They're
Yeah,
also a
they're
little bit like
hysterical. Yeah.
cringy, because you're like, oh man, I hope that's what you're being perceived as a little bit. And again, I think there is some really great conversations, and like Dr. Gupta was mentioning, this is these videos are, I do have more people coming in already prepared with questions about pain than before. I think it's interesting. A lot of the IUD specific videos focus on the pain with the tenaculum placement during the procedure, which is actually, of all the steps of the procedure, the one that most consistently, if you're using some sort of anesthetic, like local anesthetic during the procedure, like a paracervical block or topical lidocaine, has been shown to be the most effectively treated. And so
Okay.
I think the big pincer part that people come in so worried about might actually be the um, like one of the less painful parts of the procedure itself. But also, I think I get a little bit like I love that there's these videos are stimulating more conversation. But again, I see so many people who are using IUDs for medical reasons and contraceptive reasons, and who want an IUD for lots of different, like that for a lot of things. This might be like like the best option for them, and then for them to see these things and feel so anxious about it, which again I think leads to better conversations about like, well, is the office the best place for you, or do you want to try the option with sedation or virtual reality goggles, or whatever is going to help somebody feel that their pain is the is most addressed for their needs.
For their needs. Okay. That's great. Do you think, and I know both of you have brought up repeatedly lack of studies, lack of research. Do you think the new CDC guidelines will lead to more research and more studies, and hopefully improved pain management? Stephanie, I'll ask you,
Yeah,
and then we'll go to Anita.
I hope so. I think I know colleagues, and even within our own family planning division here at Stanford, there's already been some great research. There's ongoing great research
Oh, good.
about pain with IUD insertion, and I think that looking particularly for its use in adolescents with our pilot study here that we have going with the VR goggles. Like I mean, I think already this, and maybe this is, we could thank TikTok or the social media conversations for like already stimulating a lot more research. But yeah, I think for CDC guidelines to come out and say like this might be helpful is such a ambiguous word, and to be like, I think a lot of people are going to take note of that and potentially engage in more research with that.
Anita, do you think this will spur research? You've been involved a lot with national kinds of organizations.
Yeah, so, just to give you a timeline of some of the work, I mean, July of 2023 I was involved with, and prior to that, I was on the steering committee with the Gates Foundation and NIH Office of Women's Health, and they formed an Innovation Equity Forum, which is focused on women's health innovation and great. Basically women's health, which was a direct government initiative and collaborative public-private partnership. Since that date, we have worked vigorously to drive and understand a global and U.S.-centric understanding on how fundamentally how our nation approaches, women's health research. And since that date, as many of you know, in November, the White House signed a presidential memorandum on women's health research of November 2023 in the Oval Office. And then the First Lady, had an event basically in February of this year, pushing and signing on for an incredible amount of funding, for women's health research will be delivered great. Through NIH. So all of this work has culminated, and many of the people that were involved with the report through the Gates Foundation assisted to get that pushed through. So, I was delighted to be part of that, and small part of it, if any, on some of that work. And many of the people, understand. And one of the pivotal things that I was involved is to say that pain is undertreated in women. And, I'm delighted, that there will be more investment and that it has been understudied and underfunded. And hopefully we'll begin to see some of that, work in the many years ahead.
Oh, that's great. And that's a great place and a kind of reassuring and optimistic place to sort of end our conversation on. I know I was really intrigued by a study that I saw, and this was IUD placement in women who had had children, where it was asking the physician or the person placing the IUD to score what they thought the amount of pain was that that patient had experienced, and then the patient to score what their pain was. And the average, I think, score that the patients gave was on a 0 to 100 scale, with 100 being the worst possible pain, the visual analog scale, and 0 being no pain. Their average score was 65, which is not insignificant amount of pain. But the average score that the person placing the IUD gave them was a 35. So I thought that was really interesting. And I think it's something for all of us as physicians, we're all three physicians, to be really aware of, that sometimes what we assume to be true is not necessarily what the patient is feeling and experiencing. And I just can't say, I'm so delighted to have Stephanie and the GYN, the adolescent GYN group, as part of our LPCH family. I mean, we've really noticed a difference in the patients we're caring for and the level of care that they're receiving. It's just a different level. And Anita, I can't tell you how thrilled I am that I know you, and that you're on the forefront at a different level than the rest of us, really pushing these national agendas to try and improve care for women and for pain management, and the intersection of the two, which has often been really ignored. And as you said, the equity piece is not just women. Obviously, underrepresented women of lower socioeconomic status suffer even more than the rest of us do. And so I'm so happy and so excited that I know you, and that both of you are doing this ongoing work. Before we wrap up, I just wanted to see if either of you have some last minute thoughts, things that we didn't discuss that you think it would be important for our listeners to know. And I'll start with Dr. Gupta this time.
Well, first of all, no, thank you. I think that, uncovering these conversations is such important work. So I just wanted to really thank you and really, thank you for understanding that pain is an inherent part of the human experience. And each individual's experience is unique, and bringing that to the forefront is, I'm very grateful for you.
Thank you, Anita. Stephanie, Dr.
Yeah.
Cizek.
Well, I just wanted to say, like, this is so amazing that this, podcast is being led by you, and that you and Dr. Gupta, talking about this from the field of anesthesia. This has been so important to improve the what we know about pain, and how to manage pain. And I can't say enough good things about our LPCH peds anesthesia team, because they're the ones spearheading this VR goggles use in IUD procedures in the OR, and they're the ones who in the OR, when we're doing sedation for small procedures, are so interested in tailoring the sedation so that people have the best experience, both while they're asleep during the procedure, but then when waking up, that their pain is under the best control, and they have the minimal effects from the anesthesia itself. And so all I just so much appreciate, and that kind of multidisciplinary approach to pain and thoughtfulness about pain, especially for gynecologic conditions, really moves the bar.
Well, great. Well, thank you to both of you. This has been another edition of the CSA podcast, Vital Times, and I hope you will join me in the future for another episode. Thank you.